Keynote Lecture, and again this will be broadcasted and streamed live on YouTube for your colleagues and friends back at home. The second keynote will be presented by Professor Majda Thurnher from Vienna, Austria, and she will be presenting on brain abscesses. Majda.
Thank you, Johan. Good afternoon, everybody. It's my pleasure and privilege to give the second lunch lecture at the fourth module of the 16th cycle of European course in Neuroradiology. My topic today will be brain abscesses. I don't have anything to disclose relating to this lecture. This is a picture of the emergency department at a medical university in Vienna when I work. This is just a normal weekday, and all these patients are sitting there and waiting for neurologists to examine them. Most of them will have benign diseases like maybe migraine or something else and will not necessarily need any surgical or any other therapeutic interventions. But maybe some of them, maybe one of them, will have a brain abscess, which is a serious disorder. Neurologists will come, and the only tool that he or she has is something like this. So you can imagine it will probably not be enough, and they will need our help. This is a 60-year-old male patient who came into this emergency room one day accompanied by his wife. He presented with headache and a personality change. He has difficulties talking to patient, and he is a psychotherapist himself. So his wife reported a sudden episode of uncontrolled crying. Emergency CT has been performed, and here it is. We have a ring-enhancing lesion in the right temporal lobe, which certainly explains the symptoms. So what is it? Is it a necrotic primary brain tumor, GBM? Is this metastatic disease? Or is it maybe a brain abscess? All three very different diagnoses that require very different therapy. This patient was put then into magnet urgently, and here we go. We have flare, we have T2, we have T1, we have diffusion and perfusion. And the diagnosis was, after looking at all this, clearly pyogenic brain abscess. Then we looked a little bit into more details on a post-contrast T1 and see that there is also enhancing part in the mastoid region on the right side. And we almost see a track of this infection from the mastoid going intracranially. So most probably this is some kind of mastoiditis, a mastoid infection with an intracranial extension. And then we go back to our CT and look even more carefully and see there are some destruction in this mastoid region, and then start talking to the patient again who reports on recurrent mastoid infections. This is then what the neurosurgeon was doing soon after that. This is how he opens the dura, this is how he opens the brain abscess. If you have never seen it before, I will just show you a short part of this movie, so they have an impression how this looks like and how serious it is to have a brain abscess. Okay, so it's a pretty big lesion. So, if you have a patient with a ring-enhancing lesion, even if it's MR, you definitely cannot rely on enhancement. Some of them will be pyogenic abscesses, some of them will be parasitic abscesses or fungal abscesses. The others that look actually very nice and have a thin peripheral enhancement will be glioblastoma or metastatic disease. And some of them with this thick enhancement might be demyelinating lesions. So again, we cannot rely on a post-contrast or only enhancing scans. So what should we do? Our goal is, when you see a ring-enhancing lesion, to be sure, are we looking at the neoplastic lesions, demyelinating lesions, or is this an urgent situation when you have a pyogenic brain abscess or any other infectious abscess lesion? We're going to have step-by-step approach. We're going to look one by one, and each sequence will give us different information on this lesion. And the combination of all this information that we collect will give us the correct diagnosis. So let us start with this post-contrast T1. How do pyogenic abscesses look on a post-contrast T1? Well, they go from nice to ugly. Some of them have just these very nice typical lesions, but most of them don't look like this. Some are looking like this, some are a little bigger, some has irregular enhancement, and some even look like this. So from nice to ugly, so you can't rely on enhancement. Fungal abscesses have the same. They can look as a small, tiny, nicely peripherally enhancing lesion. They can be even bigger, or they look more like a neoplastic lesion than an infectious lesion. So again, also here, you can't count on enhancement pattern. There are certain other infections that might have some signs that will help your imaging signs. Such a sign is called eccentric target sign. Eccentric target sign is seen in cerebral toxoplasmosis. That's a ring lesion, and that's a dot. And the dot or line is located eccentrically inside of the ring-enhancing lesion, and it represented congested or thrombosed vein. But unfortunately, you will see this sign only in 30% of all toxoplasmosis lesions. But it's enough if you see one of them, if you have 10 of them, and one has an eccentric target sign, it will help you to give the proper suggestion. Necrotic neoplasm the same, from nice to ugly. They can have a very thin enhancement looking like an abscess, or very thick, irregular neoplastic type of enhancement. Multiple sclerosis can look like a ring-enhancing lesion, a ring that is complete going all around, or a ring that is open, and that is then called open ring sign, and that ring will be open on the cortical side, but this is easily seen on bigger lesions than on small ones. The next step, even before we start looking at advanced MR imaging techniques, after you have seen that there is a ring-enhancing lesion you're dealing with, you should go back to your old T2 weighted sequence, because this sequence will already give you a lot of information. Pyogenic or bacterial brain abscess has a very specific picture or on a classical T2 weighted image. It has a high signal intensity content in the cavity, and it has a low signal intensity of the capsule surrounding the abscess. And if you look even more carefully, you will see that the abscess has 3 layers. Fungal abscesses look different because the content is different. Fungal abscesses are centrally dark on T2, independently if they are small or big. So first thing you do, you go back to your T2 and then you look at the center of the lesion. Toxoplasmosis is difficult. It could be dark or it could be bright, so high or low signal intensity on T2 weighted sequence, depending on the stage of the lesion. Although, just personally, majority of them have a low signal intensity on T2. Tuberculoma is very difficult because here we have to distinguish, are we talking about caseating tuberculoma, which will have a low signal in the cavity on T2, or are we talking about tuberculous abscess? Because he will look like he or she, the abscess will look like a bacterial abscess. It will be bright on T2. I've just found something recent in the literature looking at tuberculomas. They claim at the T2 it's very dark in the center, but then you have like a rim that also has several layers, almost resembling a pyogenic brain abscess. Multiple sclerosis is obviously hyperintense on T2. In big lesions, or if you're in doubt and they are ring enhancing, you could look for this. You could look for a very dark line going through the lesion. The dark line represents venous structures, because you know that MS lesions are located around the venous structures, and that is called central vein sign. Not only on T2, you can only see it on T1 with gadolinium. Sometimes, not always, it's not 100%, but it's usually helpful. Necrotic neoplasm. Well, necrotic neoplasm will be inhomogeneous, usually bright on T2, like this lesion is showing, or some infections like cysticercosis might give you a special appearance, and that would be the scolex that you see on these heavily T2 weighted sequences. So with T2, neoplastic lesions, either the metastasis or glioblastoma will be inhomogeneously hyperintense on T2. Demyelinating lesions hyperintense on T2 with a dark line representing vein, and then infections. Pyogenic abscesses will have classically very high signal on T2, and all the others, fungal, parasitic, tuberculous, you should expect low signal centrally in the cavity. Okay, then we are coming to the sequence we certainly use the most to distinguish this ring-enhancing lesion, and that is diffusion-weighted imaging. So pyogenic abscesses will have homogeneously high signal on diffusion and low ADC due to restricted diffusion due to highly viscous purulent fluid in the cavity. These are other abscesses in the posterior fossa or the smaller one on the left side. Both are very bright on diffusion and have a low ADC values. Fungal abscesses can be low, high, or intermediate. So diffusion-weighted image of the content of the cavity cannot be used to distinguish bacterial from fungal, because some fungal abscesses will be as bright as typical bacterial abscesses. What we can use, though, in some of these abscesses is diffusion-weighted imaging of the wall of this abscess, because the wall will have restricted diffusion. This is published in the literature as intracavitary projections. Means these are actually fungal organisms sitting in the wall of this abscess producing mucoid material, and that has this high signal and restricted diffusion. So not the cavity, but the wall. So we can use diffusion in the walls, so bacterial abscesses will have high signal in the cavity, and fungal abscesses will have high signal in the wall. Tuberculoma, again, if this is a classical caseating tuberculoma, then they will have elevated diffusion. If it's a tuberculous abscess, they will behave like a pyogenic abscess and have restricted diffusion. Toxoplasmosis can be restricted or elevated, the same problem as we have with the T2, so it depends in which stage we find these lesions. Glioblastoma or a necrotic tumor, even if I have beautiful and nice and thin ring enhancement on diffusion, they will be dark, so they will have elevated diffusion. Why? Because the content of a necrotic abscess is actually only some necrotic changes and not really a highly viscous material. It's not highly cellular, except we have a highly cellular metastatic disease. So glioblastoma will usually be dark on diffusion and have a high ADC. This is metastatic disease, will behave the same as elevated diffusion in the center. These are exceptions to the rules that you have to know before you jump into the differential diagnosis. Hemorrhagic metastasis might be very bright, of course, on diffusion, so be sure that you're not mistaken this for an abscess and go back to your classical sequences. And the same is the case for some hypercellular metastasis. Multiple sclerosis has elevated diffusion with a restriction in the ring. So the ring enhancing part makes show you this restricted diffusion with low ADC. So this is how you use diffusion. Neoplastic lesion will have elevated diffusion in the center. Demyelinating lesion have elevated diffusion, and pyogenic abscesses look very bright on diffusion and have restricted diffusion due to high viscosity content of pus in the abscess cavity. And moving to MR perfusion, that will be our next step. Great sequence for differentiation of ring-enhancing lesions. Pyogenic abscesses will have low perfusion, low RCBV. Very rarely, if you look, they can have a very thin red rim of increased RCBV at the edge. This is because of some vessels and capillaries in the abscess capsule. Parasitic abscess, toxoplasmosis, will also have a low RCBV. These are also infectious lesions, so there is no particular reason to have high perfusion. The same as tuberculoma. Tuberculoma will also have low perfusion, low RCBV. That's different with neoplastic lesions, so that is your key sequence. If you see this glioblastoma that I have shown before, you see at the perfusion, so the periphery, the enhancing part of the lesion has increased RCBV, increased perfusion. Why so? Because we have neoangiogenesis. We have pathological tumor vessels in the enhancing solid parts of the tumor located at the periphery in a case of necrotic lesions. I have just zoomed these two cases, two glioblastomas, both looking like ring-enhancing lesion, and on perfusion, clearly, both lesions have an increased perfusion at the periphery of the ring. Metastatic lesions behave the same. If they're small or big, you see the small metastasis that has this increased perfusion in the rim, or the one that I'm showing here that has these solid parts here lateral. They also have restricted diffusion, that's real tumor tissue, and then increased perfusion here. Don't expect this perfusion to be increased maybe all around, because if this ring is very thin, then you might not see it. Look at the thickest part of enhancing rim and then check on perfusion if you see increased perfusion. And obviously, in demyelinating lesions, perfusion will also not be increased. So this is, I put them all together. On one side, you have all these infectious lesions that produce ring, bacterial, fungal, tuberculosis, toxoplasmosis. There will be, let's say, negative on perfusion, and they have a low perfusion in the enhancing part. On the other side, are necrotic lesions like glioblastoma or metastatic lesion. So this is, again, what you have to see. So it's clear that perfusion is really helpful in distinguishing ring-enhancing lesion. Let's move next step. The next step will be susceptibility weighted image. Initially, we thought a susceptibility weighted image will show you blood products. So why would you use this for infectious diseases? And it's actually extremely helpful. Pyogenic abscesses have a special appearance on SWI called dual rim sign. So based on the literature, they say that the rim is going all around, so it is complete, and it has two layers. Dual rim means that you have two layers. The outer layer is always the dark one, and the inner layer is the white one. This is another one in the posterior fossa. Nicely, you even see those layers on T2. Remember that the capsule has different layers on T2, and this is exactly what we see on SWI. I just put the T2 and SWI together, so obviously it fits, and it is understandable why we see this dual rim sign in pyogenic abscesses. How about fungal abscesses? Do they have a dual rim sign? Well, they don't. They look more like tumors. Their rim is very thick, not really dots and lines, but a thick black rim on SWI, even on a 1.5 or 3 Tesla, the same. So SWI is obviously very helpful if you want to distinguish bacterial from fungal, dual rim sign pyogenic, and thick dark rim fungal abscess. Okay, this is just another two, so you have seen several examples, the one in the posterior fossa and the other one in the frontobasal region. Okay, so this is how we should distinguish bacterial from fungal again. You see, this is now a combination of two sequences. You use diffusion and SWI, and then you have this bright center dual rim sign and bright walls with a thick black rim. So for tuberculoma, it's a little bit difficult. I was searching the literature, not much literature on SWI in tuberculous lesions, but I found something published in 2018 where they found actually a dual rim sign also to be very common in tuberculomas. I personally do not have a lot of experience, but somehow it seems logical to me. It's also bacteria, so probably it's logical that tuberculomas would also have this dual rim sign, but I think we will have to wait for some more literature to be sure that this is true. So now, neoplastic lesions. Neoplastic lesions have dots and line on SWI. You know, these intratumoral susceptibility artifacts that you see, more or less. So that looks very different. And multiple sclerosis on SWI will show dilated veins. If the lesion is big, it's easier, even if you do dynamic perfusion and you really see these dilated veins in a case of tumor-effective demyelination. When the lesions are small, that's maybe not always so easy. Let me show you another case that I got from Brazil, from a colleague of ours, Leonardo Macedo, who is also frequently lecturing at our courses, showing this huge region, very thick rim, but then on SWI and this perfusion with a lot of dilated veins, which leads to the proper diagnosis of a tumor-effective demyelination. So again, I'm just putting this all together so that you have seen it one next to each other, dual rim sign bacteria, fungal abscesses, thick black rim, multiple sclerosis, dilated veins, and then dots and lines in case of necrotic tumors. Here it goes, once again, how you should distinguish this. Okay, the last sequence that is left, it's MR spectroscopy, maybe the most complicated one and difficult, certainly, especially in emergency conditions if patients are not doing very well. So for distinguishing between pyogenic, fungal, glioblastoma, we don't really use a spectroscopy. All the other sequences are probably enough. Just in questionable cases, I would use spectroscopy if I'm not sure if I'm suspecting tuberculous infection, because in these tuberculomas, they will have a very high lipid peak. So this is the only situation when maybe you say, okay, nothing else is helping, and we should maybe try MR spectroscopy. This is also from the literature when they were looking at tuberculoma, metastasis, cysticercosis, and found this high lipid peak basically in tuberculomas or metastatic disease. Okay, so this was easy. This is pretty simple, or maybe just simplified. But there are some challenging cases that never fit to these rules that we just established. And one of these is this one, when I myself made the wrong diagnosis or made the wrong assumption, and I keep showing this case. Ring-enhancing lesion, I think a child, 14 years old, headache, no medical history, nothing really. Inhomogeneous on diffusion, a little bit restricted, a little bit elevated, low perfusion. So starting with here, I was sure I'm dealing, of course, with infectious lesion because the perfusion is low. And it doesn't look like a bacterial abscess because diffusion is not homogeneously bright. And then looking at SWI, I thought this is definitely not a pyogenic abscess because it has hemorrhage in the cavity. And this is something very characteristic for fungal abscesses. After talking to clinicians, they explained to me there is no reason to have a fungal infection for that child, not immune compromised, nothing. So there was a question. We kept saying, based on imaging, we would go with a fungal infection. Of course, the final diagnosis was hemorrhagic pyogenic abscess due to Streptococcus aeruginosus. Okay, so what is your next step? It's not about making the wrong diagnosis. It's about going back and reading. Maybe there are some cases or circumstances where it will lead you to such a picture. This is another companion case, the same, huge abscess, bright on diffusion, and we were also sure this is an abscess. And looking at SWI, it's confusing again. Now everything looks like an abscess, but SWI looks like a tumor. I just told you, dots and lines. So again, how can that now be bacterial abscess? And it was a pyogenic abscess. So, you know, these are cases that you can easily make a mistake. And this is now the third case when it doesn't fit that I found in the literature when I was searching these exceptional cases. And this is one that has not even restricted diffusion in the cavity, has increased perfusion at the periphery, and has a very dark black rim. So all the three findings, that doesn't fit to bacterial abscesses. But it is one. So it looks like there is a certain neoangiogenesis, even we associate this terminology only with tumors in pyogenic brain abscesses. So let's go back to pathology. We have 4 stages in a brain abscess: early cerebritis, just 3 days, late cerebritis. Then we have this early capsular formation, and that's the one. That's the one that is the stage, so-called the young abscess, when we have a higher capillary density. So if you see an abscess in that very stage, you might have this increased perfusion, which you will not see later. And that is the stage that you could make a mistake by following our radiological rules. Be very also careful with postoperative abscesses. So postoperative abscess that arises in a postoperative cavity is completely different than an abscess that is just spontaneously. So there were studies looking at diffusion. Can I rely on diffusion restriction in postoperative cavity? You know, when a neurosurgeon is asking, why is this so bright? And you say, because it's an abscess. Well, that's not really true. We have to be very careful. So diffusion has a limited value in postoperative abscesses. So the cavity usually has a higher ADC that you would expect in a spontaneous abscess, or could even have elevated diffusion, and that is still an abscess. So be careful by using this as a 100% rule. So these are situations where you can make mistakes, and that is pyogenic brain abscesses can have hemorrhage in the wall, they can have neoangiogenesis, and they do have it in an early capsular stage. You might then see increased perfusion. Pyogenic abscesses can even have hemorrhage in the cavity, so put still pyogenic abscess in your differential diagnosis if the patient does not have any other reason to have a fungal infection. And diffusion does not have a very high value in postoperative abscesses. Okay, so here we are. Here our ring enhancing lesion that I showed at the beginning. It looks like that we have all the tools. We just have to use them properly. How should we use them? Use MR perfusion to reliably distinguish neoplastic from non-neoplastic. Use diffusion and SWI as a combination if you want to differentiate pyogenic and fungal. Use spectroscopy in questionable cases where you are suspecting tuberculomas, and do not underestimate T2-weighted sequence. So the only approach that you can have, because you need a lot of sequences and combination, is to use step-by-step approach, and then you slowly navigate yourself from imaging to pathology. As you see how complicated it could be, there is a working group of the European Society of Clinical Microbiology and Infectious Diseases on brain abscesses, and we are now working on brain abscess guidelines for the diagnosis and for therapy and also treatment monitoring. And I'm very happy as a neuroradiologist to be part of this group. These guidelines will be published and are scheduled in 2023. So here we go. Here we have our rings with all these sequences. You have certain rules, you have certain exceptions, and I would like to finish this lecture with saying that brain abscess is a very serious diagnosis, and to avoid any mistakes, any delay in diagnosis or permanent neurological deficit, we have the tools, but you just have to use it. You choose and use them wisely. And I thank you very much for your attention.
That was a great lecture, no? I think it's wonderful. Thank you, Majda. So we go to the workshops again this afternoon. Only one message. Don't forget to scan your badges when you enter each workshop room. You have like 5 minutes and we will start the first workshop. So good luck this afternoon.